Thank you for the opportunity to present. I'm one of the PGY2s in the Plastic and Surgery Reconstructive Program. So when you're a junior doctor, you're told to repair wounds at different times. And when you get a facial laceration, your seniors tell you take out sutures at 3 to 4 days, but on the back, leave it longer. And that always was something that I didn't really understand, but it always gave better scars in the face compared to the dorsum. And your seniors will tell you that's because there's better blood supply, there's less mechanical tension. But given the age of where we are in fibroblast biology, especially within our own lab, I really questioned, well, maybe there was something else into that statement that they were telling us. And like before, there's usually someone with the same idea. And actually, someone at Stanford actually found that human fibroblasts from different regions of the body actually had different transcriptomes, and they keep this behavior when you plate them in a cell. Within our own lab, cells from the face had much more regenerative properties than the rest of the body. And even though these studies were mostly in human, I was even more lucky to understand that actually mouse fibroblasts are very similar to humans. And their embryonic origin, so where they're from, is the same in a mouse and a human. So facial fibroblasts, just like in a mouse, are derived from the facial neural crest, and from the back, they're derived from the somite. So I question actually why we see differences in scarring around the body is because fibroblasts are derived from different embryonic origins. And maybe if I reverse this, so I make facial dorsal fibroblasts act like dorsal fibroblasts, I can actually reduce skin scarring and overcome skin scarring. So the first thing we always do, I needed to create a mouse model to reflect what I was seeing in the clinical situation. And so I create 2.5 millimeter punch biopsies within a mouse within the different areas of the body. And here's some early histology results just to show that, yes, the areas when I didn't touch the wound was very different. But when I created scars after 14 days, just like I saw in my patients, the dorsal wounds were very, very thick and the facial wounds were very thin. So I had created the same thing I saw in the clinic now in my mouse models. So then I submitted for single RNA sequencing. I extracted those fibroblasts and found at day 14 in the face, there were very specific types of fibroblasts compared to the dorsum. And yes, they were different exactly between the dorsum and the face. So there was something within these facial fibroblasts that was allowing these wounds to heal better. And there's lots of different pathways came up, but one thing that popped out to me was Robo2. Had never seen any types of wound healing. And one thing that was interesting is Robo2 sits on the surface and actually allows neurons to come together. So there's sort of a neurocrest angle. Using facts, I could confirm that within my hands, I could get Robo2 to be expressed at a protein level. So really, if these facial fibroblasts were expressing Robo2, what would happen then if I transplant them into a dorsal wound? I should be able to see some regeneration if Robo2 was really relevant. So using CRISPR-Cas9 technology, you can overexpress and downregulate proteins, which allowed me to do this experiment. And just to what I was thinking, when I transplanted facial fibroblasts that had no Robo2, I was getting thick scars, no hair follicles. When I was overexpressing, I started seeing the reverse. I see lots of hair follicles and no collagen, both at an IHC level and a PCR level. But what was the most striking thing for me and allowed me to continue was that these dorsal wounds started to express neural crest markers. So fibroblasts in a dorsal wound should not be expressing SOX10, but when I transplanted, it did. So then I went back to my single cell. Robo2 isn't that relevant. It sits at the cell surface, so what goes beyond it? Well, I went back to the single cell and looked at, well, EID1 was starting to be expressed more in these facial fibroblasts compared to dorsal fibroblasts. And what does it do? Well, it actually is involved in histone acylation and actually allows collagen to be downregulated. So it seemed to be interesting. And cells that express Robo2 also expressed EID1. And when I knocked out Robo2, I saw less EID1. So I'd now started a pathway. Robo2 acts on EID1, which is known to inhibit EP300, which allows facial cells to allow for regeneration. So I did the same experiment, but went down in my ladder. So now I'm overexpressing and knocking out EID1 in facial fibroblasts that are being transplanted into dorsal wounds. Again, when I knocked out EID1, I saw scar. But when I overexpressed it, I saw hair follicles, no collagen deposition, and also high levels of my neural crest marker SOX10. So again, I was changing these dorsal wounds to act like facial wounds. But as a plastic surgeon, I'm not going to start transplanting facial fibroblasts into wounds. So what could I do? Well, if I could find a drug that did the same thing as EID1, so inhibit EP300, I could reduce scarring. So I went back to my mouse model and inhibited EP300 using a available drug, and saw again that when I treated dorsal wounds, now they were becoming like facial wounds, low collagen and expressing my markers of SOX10. But we didn't just show this on a histological level. I performed Visium analysis, codex analysis to show at a spatial level, the fibroblasts now within these wounds that had treated with this EP300 inhibitor were having neurocrest origin. They were showing my pathway of interest. But we didn't even stop there. So yes, we found this new pathway is now relevant, but actually how was EP300, this last molecule at the end of my pathway, working? Well, actually we found using single cell attack that it was actually reversing the histones. And so I performed a very dedicated and very specific form of ChIP-seq analysis, which showed the histone acetylation between the EP300, which you know is a very enhancer. And we found that in our dorsal fibroblasts, there was lots and lots of acetylation, but in our facial fibroblasts, there wasn't a lot of level. And this was both globally and around genes that are known to cause extracellular matrix formation. But when I applied my inhibitor, I saw a downregulation of acetylation, just like in facial fibroblasts. And just to really confirm this, when we did the same experiment in our CRISPR knockout cells, so these cells now in the dish do not have any signs of EID1, we were allowing our cells now to reverse that. So when I didn't have EID1 in our system, these facial fibroblasts had high levels of acetylation. So this really confirmed to me that maybe the facial environment is because we have less acetylation, and it was sort of creating a silent epigenetic phenotype. And my last question is always, I work in mice pretty much every day, but is this really going to be relevant to patients? Well, actually, I think it will, because we took human scars from our patients and we found similar things. We saw high levels of EID1 in Robo2 in facial scars, but not in back scars. And now with the era of everyone giving our data publicly available, in fetal fibroblasts, we also show high levels of Robo2. So I really want to convince you that actually why we take out sutures might be because we get told to do it. It actually is because these facial fibroblasts have high levels of this pathway, Robo2, EID1, EP300. And actually by now understanding that, I can manipulate that and make dorsal fibroblasts act like facial fibroblasts and reduce skin scarring. Thank you. So I'd like to thank all the members, especially Jack Lee, who's one of my really close mentors in my lab, as well as Jason Guo. Thank you.